and headache in general with a focus on migraine. I'm going to talk a little bit about what is known, first of all, covering not only migraine, but a couple of other sleep-related headache disorders, and then get into managing sleep and migraine, which I think normally generates quite a lot of discussion. So I think the questions that people pose are often more useful because we can get really into the nitty-gritty of sleep and migraine. So do feel free to ask anything. I may not have the answer necessarily, but I can certainly try and work towards the right the right path for a good answer. So I don't have any major disclosures before we begin. And I think we'll get stuck straight into the sort of headache disorders which are associated with sleep problems, sleep disturbances, starting off with migraine. So what do we know? Well, Azuna's already alluded to the relationship between sleep and migraine is pretty clear. As migraineurs, you will know that. You will have noted that sleep can be a trigger for migraine. Sleep can perhaps also be a feature of migraine attacks. And I think Anish Bara may talk a bit about that later on today. And sleep disturbances can occur during a migraine attack, before and after. Now, surprisingly little is actually known about this. If you look at the graph here on the right of the screen, this is what we call a meta-analysis of all of the types of studies that have looked at triggering in migraine. And what they've done is they've ranked in order the triggers that people report are the most potent triggers for migraine attacks. And you can see in pole position is stress, followed by sleep. And the relationship between stress and sleep is also difficult. So there's an interrelationship there as well. So very high up on the list of triggers, when you look at the academic studies that have measured this kind of effect size. What's difficult about this is when we talk about sleep, it's very hard to hone down on one particular thing that might be a trigger. So is it too much? Is it too little? Is it broken sleep? Is it poor sleep? Is it what we call rebound sleep, when you haven't had enough sleep for several days and then you suddenly sort of crash and have several hours of sleep? Is it tiredness? Is it lethargy? Is it fatigue? Is it insomnia? Is it snoring? There are all sorts of little features and facets of sleep that it's very hard to tease apart. But generally speaking, what we think is that the trend is too little sleep is more important as a trigger than having too much sleep. However, as a lot of you will notice, when you've gone for several days with too little sleep and then you have this sort of mega catch-up sleep, it's often that may be the more triggering phenomenon. Now, what we're trying to work out in the sort of science arena at the moment is whether or not sleep disturbances before a migraine attack are part of that migraine attack. Now, we're aware of these features called premonitory features in a migraine attack, which start, hours to 2 days before the pain of a migraine attack starts. And these can be things like cravings, yawning, fluid retention, needing to go to the toilet more often. These sorts of changes are driven by the brain. They're driven by an area of the brain called the hypothalamus, which also regulates sleep-wake cycles. So a question that we don't know the answer to yet, but we'll hopefully look into in the next few years is, are these sleep disturbances that people associate with triggering their migraine, is that actually part of the migraine attack that's already started? So if you have a couple of nights of really poor, rough sleep with insomnia and then have the pain of a migraine attack, is that actually your brain already having started a migraine attack? And what we're seeing is the sleep disturbance reflects brain changes generating the migraine attack rather than actually the poor sleep triggering. So the analogy there is chocolate. When people consider chocolate being a trigger of an attack, actually probably what we think is that the brain is causing you to crave chocolate and crave sugar as the attack has already started, rather than it actually triggering the attack. So quite a lot of work to do figuring out the changes in sleep patterns that might occur before a migraine attack. Now, what do we know about the timing? This is interesting, and there's been a little bit of work over the last few years that suggests that if you're a morning lark rather than a night owl, so someone who is up and about quite early in the morning, then you're possibly more likely to be a migraineur. this is really reinforced by a very rare condition called familial advanced sleep-wake phase disorder. Now, this is a sleep disorder where it's an inherited disorder. Families have this particular problem. There was one group of families in Utah in the United States who are all farmers. And they're farmers probably through choice, because they feel at their most productive getting up very early in the morning at 4 o'clock and going to bed at 7 o'clock in the evening. But what they found in these families with this very extreme morning lark behavior was that they also had migraine with aura. So there's a clear co-association between migraine with aura and this very unusual, quite rare sleep disorder, familial advanced sleep-wake phase disorder. And the scientists in the States have actually found a mutation in a particular clock gene that causes this sleep disorder. And colleagues of mine at King's, Phil Holland and Jan Hoffman, are looking at a mouse model of this disorder now to see whether or not there's anything that they can learn from studying and examining behavior in these mice that actually might make them more likely to have the kind of brain chemistry or brain structure that relates to also conveying a risk for migraine. So there is probably something in the body clock's timing that makes people more likely to be slightly earlier morning lark and a migraineur. This graph here is a really messy graph, but I think it's a great study. This looks at tweets that people have made over a 1 week period in the United States. So they're controlled for each of the time zones in the USA. And they've looked at the density of, I think it's hashtags. So people have said hashtag migraine, and they've complained of having developed a migraine attack. And it's looking at the timing of that. So you can see not many people complain of it overnight, but then once they're starting to wake up 7 o'clock in the morning, there's a bit of a peak by about 10 o'clock in the morning, and then a bit of a dip. And then again, that peak rises towards the afternoon. This is really good, huge volumes of data. This is 14,000 individual tweets that tell us a little bit about timing of when the attacks actually start or when the pain starts to manifest. And I think really what you can tell from this is that people tend to describe the attacks more commonly happening in the morning, around this time actually of the morning. So apologies to those of you who are in the midst of an attack at the moment. What do we know about sleep and sleep quality in people who have migraine? Well, again, surprisingly little. This recent study that I had the pleasure of working on with colleagues Emily Stanier and Jan Hoffman at King's, is the sum total really of studies that have been conducted over the last 20 years looking at sleep quality in patients with migraine. And all we can really tell by analysing these studies is that sleep quality is poorer in people with migraine. I don't need to tell you that, but this sort of really solidifies that this is the case looking over academic studies. And also there are some changes in what we call sleep architecture of people with migraine. So sleep architecture is the electrical activity of the brain through the night. And looking at the small number of studies which have studied electrical activity of the brain through the night with sleep studies, it's evident that people with migraine perhaps have slightly less rapid eye movement sleep or dreaming sleep than control patients who don't have migraine, who have had the same sort of sleep studies. That's a very small association. It's not something that's a robust association. It's not something we can confidently hang our hats on and say there's a very clear difference, but there's a suggestion that there may be a difference in the physiology or the biology of people's sleep with migraine compared to people who don't have migraine. So what about sleep disorders and migraine? Well, the two commonest sleep disorders to have if you also have migraine are insomnia and restless leg syndrome. Surprisingly, and I'm always fascinated by this as a doctor, insomnia, like migraine, incredibly common. Probably the two commonest reasons to see your doctor are not sleeping well or having a headache, yet they are supremely badly managed sort of in general. So it's very difficult for people to understand what insomnia is, which sounds strange because we will have all have suffered from it. So a good sort of screening question to ask yourself when you think, do I have insomnia, is do you not only have difficulty falling asleep, so that's the common thought that insomnia is problems getting off to sleep, but it's also problems staying asleep. There are two types of insomnia. There's this sleep initiation insomnia, which is the commonest type. There's sleep maintenance insomnia, where you really can't maintain your sleep and you're waking up several times at night, finding it difficult to go back to sleep. And then there's a rare and slightly more problematic to treat insomnia, which is what we call end insomnia, or more dramatically, terminal insomnia, which just means that you're waking up very early in the morning and unable to get back to sleep. So insomnia is fairly prevalent in people who have migraine. If you look at these studies, and I'm not going to go into these in too much detail, but these are big population studies typically performed in Scandinavia. And an odds ratio tells you the odds of having insomnia if you also have migraine, or vice versa. And typically you have about 40 to 80% increased odds of having one or the other. Now, this is increased odds, not risk. So what it doesn't mean is that you've got an 80% risk of having insomnia if you have migraine. Your odds have increased by 80%. So they're subtly different. We know, if you look at the bottom line here, that the odds of developing insomnia after 11 years of high frequency migraine, so this is 7 or more days a month, is greater. So your odds are about 120% greater if you have this high frequency migraine, so several days a month with migraine, over an 11-year period, you're much more likely to develop insomnia during that period. Now, the other thing that can cause insomnia is restless leg syndrome. And one of the fascinating things about restless leg syndrome is that it's incredibly difficult to describe the feeling or the sensation that people have, other than there being restlessness. Now, you ask people who suffer from restless legs what it feels like, and it's incredibly difficult to pin down a particular word in English or any other language that describes the sensation. So it's not really a pain. It's not sort of a discomfort. It's an unpleasant feeling. It gives you a compulsion to want to move your legs to relieve that sensation. The best description that I had in clinic recently was somebody saying that they felt as though their bones in their legs were being tickled with a feather. So some of you, that will resonate, this really sort of difficult to describe sensation that happens in the evening, doesn't happen in the morning, it's not there when you wake up, only happens in the evening, gets worse the closer you get to bedtime and the closer you get to want to fall asleep, and really sort of compels you to want to stretch or move your legs just to relieve that sensation. Now, it's not the same as leg jiggling. So lots of people sort of jiggle their legs nervously through the day. This is a very different type of sensation, and that can stop people getting off to sleep. So that can cause sleep initiation insomnia. And again, we know that people with migraine have an increased likelihood of having restless leg syndrome. Why? Well, there are some brain pathways that are involved in both, which Peter Goadsby and colleagues have looked at in the past. There are also neurotransmitters involved in both problems. So dopamine is involved in migraine, and it's also involved to some extent in restless leg syndrome. So there are clues, I suppose, in brain structure and brain chemistry to suggest why the two might be linked. Restless leg syndrome is also slightly commoner in women, as we know migraine is. So what about the other sorts of sleep problems that people with migraine might have? Well, snoring is thought to perhaps be a risk factor for migraine. In theory, it's more likely that if you snore heavily, you may develop chronic migraine. So you may go from episodes of migraine to developing more chronic migraine. Quite what the risk is or what the odds are, it's hard to say. It's probably small, but there is some suggestion that there's an association. Now, that association increases a bit when the snoring becomes more severe and you develop something called OSA, or obstructive sleep apnea, which is a very common sleep problem. But we're not entirely sure what's causing this. Now, the old theory was this is low oxygen. When you snore at night or when your breathing pauses, your oxygen levels dip down a bit, and that must be having some effect on the brain. I don't think that's right. I think it's actually the fact that snoring and sleep apnea are waking people up, even subconsciously, just waking them up several times through the night. And it's that fragmented, disturbed sleep that makes the thresholds for triggering migraine much lower. Again, this isn't an absolute association. There's just perhaps a suggestion that if you're a heavy snorer or if you have obstructive sleep apnea, you may be more likely to have migraine, and you may be more likely to progress from having episodic migraine to more chronic migraine. So this picture here on the right is a person wearing CPAP, which stands for continuous positive airways pressure. That's the gold standard treatment for sleep apnea. You can see it's pretty cumbersome, not something that most people want to wear at night, but incredibly common. You'll know people, there'll be people in the audience that use it. You'll have friends and family members who use it. And the idea is that air is pumped from this pump on the bedside table into the mask under some pressure. It's warmed and humidified, but that pressure splints open the airways. So rather than the airways flopping down on themselves, causing snoring when you're asleep or causing your breathing to pause, actually the pressure of the air splints open those airways, allowing you to breathe in and out without any kind of obstruction. And that stops you from waking up through the night. So generally, it's a very effective treatment, but it's not something that's tolerated by everyone, just given the amount of paraphernalia and difficulty using it. So people have tried to sort of theorize how these situations arise with migraine and insomnia. And this is a really nice model that looks at a vicious cycle. So how does this vicious cycle start? Well, we know that when you have head pain, that can reduce your melatonin levels, can also cause your sleep to fragment. We know then that that sets up slightly unusual coping behaviors. So people may nap more during the day if they've had a really poor night's sleep. If they've got a migraine attack, they may take themselves for a nap to try and terminate that nap. They may use caffeine either to stay awake or to treat the migraine in some cases. They may use medication. Most people in this arena probably won't be using opioid medications, but opioid medications are very commonly used for head pain. That can cause insomnia. So these sort of coping behaviors can set up instability in sleep-wake cycles and sleep-wake timing, which can move the threshold for developing chronic insomnia. And then chronic insomnia can feed back into this pain cycle by, again, reducing the thresholds for developing head pain. So it can become this really quite entrenched, difficult cycle between migraine and insomnia, which we'll talk about in the second half, ways in which we can try and break this cycle and treatments that we can use to try and get on top of that, mainly around avoiding some of these coping behaviors that people quite understandably start to do just to cope with the sleep loss and the head pain. So very briefly, I'm going to move on to cluster headache. Some of you in the audience may have cluster headache, and I'm mentioning this purely because not only is it a horrendous type of headache, it's perhaps the worst pain that people can imagine, but there are very clear features of cluster headache that implicate sleep and implicate body clocks. Now, this is not new news. This is very old news. So Thomas Willis, the very famous British neurologist, first described this back in the 1600s, where he described a patient who was having these attacks of pain one side of the head that would come in bouts or clusters around the equinox and the solstice, and they would really, the language he uses here is phenomenal. They would infest at certain fixed hours of every day and every night. And that's what people with cluster headache will tell you. Their attacks can come on like clockwork. So you can almost time your watch by them, particularly at night time, wake you up from sleep 60 to 90 minutes after you've fallen asleep. Boom, there goes the first attack. And then there'll be regular attacks through the day. So we know that a lot of people, at least half, maybe 80% of people with cluster headache have attacks that arise exclusively from sleep or mainly from sleep. They'll be woken by the attack. They won't wake up and then develop an attack. The attack will actually wake them from sleep. So slightly unusual feature of cluster headache. And there are these timing peaks. So the graph on the left here shows the peaks of attacks in men and women in Denmark in a recent study. And you can see that when you look at the time of day, they're all very similar times of day that these attacks are occurring. And then this is an old graph on the right, but a fascinating one. This looks at people who have phoned the doctor. This is one neurologist in Los Angeles who have phoned up the neurologist and said they have just started a bout of cluster headache attacks. And he's correlated that to day length. So the top graph there is the length of daylight, and the bottom graph are the number of calls his office has received to say from patients, I'm going into a bout of cluster headache attacks. And you can see there's a peak just after the solstice, the summer solstice and the winter solstice. And there are these little sub peaks just after the equinox. So there's something about light duration and light intensity and seasonality, all of which buys into sleep and biorhythms, biological rhythms and body clocks. That's very important in cluster headache that we're yet to figure out. But I put this graph from 1987 because actually, interestingly, in the last, I'd say 3 or 4 weeks, and I don't know if there are any other headache doctors in the audience, but last 3 or 4 weeks, lots of emails from patients saying they've gone into bout and needing treatment. So I think this stands up. I think this really sort of drives home the fact that there are these biological factors involved in timing of certain headache disorders. So we know that obstructive sleep apnea that we've just talked about is perhaps more common in cluster headache than it is in migraine. The difficulty with both is that if you treat the sleep apnea, you're not necessarily going to treat the migraine or the cluster headache. You might feel better from treating the sleep apnea. People might feel less tired during the day. They may sleep better at night, but you don't necessarily always improve the migraine or the cluster headache in parallel. So just something to be aware of. This chap here is wearing a slightly different mask to the lady in the previous presentation. He's got a nasal pillow in. Some people can find that more comfortable not to have the sort of gear covering their faces. And then lastly, hypnic headache is a very rare primary headache disorder. I think maybe, and I have an interest in this area, I've seen 2 or 3 patients with hypnic headache. It's again a headache that arises exclusively from sleep. Patients are woken by the pain. Tends to be slightly less severe than cluster headache, probably similar severity to migraine, perhaps slightly less severe than migraine attacks. Tends to affect older people, more women than men, and it's quite featureless. So unlike a migraine attack where you have the photophobia, you have sound sensitivity, you have nausea and vomiting, hypnic headache's really just the pain. About a third of people will have a previous history of migraine, so we're not sure whether or not this is just a variant of migraine or a separate headache disorder. This is a very detailed table here, but it summarizes these 3 different disorders. And the key things to pick out are that hypnic headache attacks are exclusively derived from sleep. Headache of cluster headache very often occurs from sleep, and migraine attacks will occasionally occur from sleep. Hypnic's very rare, as I've said. Cluster headache's also quite rare, about 1 in 1,000. Migraine's very common, so 1 in 7 of us will have migraine at some stages in our lives. Now, another way to sort of tell the nuances of these attacks apart are that a hypnic headache attack may get you to sit up and maybe get out of bed and go to the toilet, get back into bed, maybe go and get a glass of water and walk around. A cluster headache attack will throw you out of bed. You'll really be holding your head, rocking, rolling on the floor. There's a lot of activity there. Yet a migraine attack, with the sensitivity of the head, what you probably prefer to do is lie very still and not get up, not move about. The reason to make a distinction between these 3 problems is that they're treated differently. So they have very specific treatments that work better in one condition than the other. So that's why I bring it up here. Now, very briefly, there are a couple of other types of headache. There's sleep apnea headache, so that's different to migraine and cluster headache. People with sleep apnea, about 10% of people with sleep apnea, will report a headache in the morning when they wake up. So a dull headache that lasts an hour or 2 that then just disappears through the day. No vomiting, no nausea, but just a dull headache. And the key difference here is that when they have treatment for sleep apnea, the headache goes away. It literally melts away. It's the thing that people will come back to clinic and tell me most often, headache's gone. I feel more awake during the day and the headache is gone. So it probably is a subtly different type of headache disorder to migraine. Doesn't matter on the severity. So you can have very severe sleep apnea, you can have very mild sleep apnea. Your chances of having the headache are about 10% if you have sleep apnea. Then there's bruxism. Bruxism is quite a difficult area because there's no evidence-based treatment for it. It's grinding of your teeth at night time. And what that can do is put pressure on the temporomandibular joints, which if you have chronic head pain can already be quite sore and inflamed. And there's probably a relationship between chronic head pain, chronic migraine, and temporomandibular joint dysfunction. It's difficult to know how to treat it. So there are sort of gum shields that people can wear, devices that keep your jaw slightly forward. Amitriptyline might be useful, or Botox may also be useful. It's quite common. So dentists, a lot of you will have been to your dentist, and they may say when they examine your teeth, there are signs of bruxism. So it's a common problem, and the exact relationship is a little bit unclear. So what should we think about when we talk about treating or managing sleep and migraine? Well, the topic that comes up most frequently is melatonin. So melatonin is a hormone that your brain produces at night time anyway. When your brain signals light levels dropping at night time, there is a pathway that stimulates the pineal gland, which is a little gland at the center of the brain, to start producing melatonin, which is a hormone and a transmitter that makes it easier to fall asleep. It doesn't cause sleep, but it sort of sets up all of the right pathways, all of the right transmitters to tell your brain that it's nighttime, and then it just allows you slightly more easily to fall into sleep. It doesn't work particularly well as a sleeping tablet, although people do use it. It works best as a sleeping tablet when you have to sleep times that aren't nighttime. So a shift worker may want to use melatonin during the daytime to help them sleep. That's where it works best as a sleeping tablet. There are some clinical trials, one small clinical trial that suggests that using melatonin, 3 milligrams of melatonin at nighttime, is the same or equivalent to using 25 milligrams of amitriptyline at nighttime. So many of you will be taking amitriptyline as a migraine preventive. So there's some small evidence from a small clinical trial to say that melatonin might be similar in efficacy to amitriptyline. I point out that this is a very small trial. Some of you will have tried it, some of you will have not got on with it. It's quite difficult to get hold of in the UK, melatonin, so it's a prescription-only medicine here, whereas many of you will know in the United States, Australasia, you can buy it over the counter. The difficulty with doing that is that the preparation strengths, doses, quality varies wildly, so it's very hard to draw conclusions. There's some evidence that using melatonin may be helpful. You have to use it in much higher doses, though, for cluster headache, we've noticed. So what about the treatments that you're using, and what impact might they have on your sleep? So the commonly used medication for an acute migraine attack would be a non-steroidal anti-inflammatory, things like aspirin, naproxen, ibuprofen, diclofenac. What do? Well, they can actually suppress your melatonin secretion when you take it at night time. So that might have an effect on sleep, but it doesn't tend to affect sleep in any other way. It doesn't affect the architecture or the structure of sleep. Triptans, so many of you may notice that you can feel a bit sleepy after taking a triptan. What's interesting there is that depending on the triptan, so there are some triptans which really penetrate the brain or get into the brain much more easily than other triptans. So elatriptan and zolmitriptan are absorbed through the blood-brain barrier more so than, say, sumatriptan or almatriptan. So some people may complain with elatriptan or zolmitriptan of feeling a bit sleepier. What we don't know if whether or not this is a side effect of the medication, or if this is just a symptom of the migraine attack. So you've treated the pain, And then are you unmasking this tiredness or this sleepiness as part of the migraine attack? Or is it a side effect of the triptan? We don't know. We think probably it's more likely to be you've treated the pain or you've dampened the pain with the triptan, and then you've unmasked this sleepiness afterwards. So we think it's probably more related to the migraine attack than it is a side effect of medication. So various other things, propranolol, people who take propranolol may experience vivid dreams. So we know that it disrupts or fragments dreaming sleep a little bit more than other medications. Amitriptyline might help with sleep. It can make some people feel very groggy the next day. Topiramate that some of you may be taking is fairly sleep neutral. It doesn't really have many sleep effects. So what other things can we do? And I realize I'm running slightly over time here, but we'll just cover these in a little bit of detail. Insomnia. So those of you who have insomnia, there are things that can be done. We'll go over that in the next few slides, but there are a couple of clinical trials to suggest that cognitive behavioral therapy, which is the first line therapy for insomnia, can also be helpful for migraine. There are a couple of medications people use for insomnia that can also perhaps be slightly more helpful for migraine. So mirtazapine and melatonin are two that are commonly used in insomnia clinics. If you have restless leg syndrome, one thing that might be very helpful to do is check your iron levels. So people with lower iron levels are more likely to have restless leg syndrome, and then improving your iron levels can help mitigate that symptom. There are other medications such as gabapentin and pregabalin that are sometimes used for headache, although not particularly good for headache, but they don't make headache worse, that are very good treatments for restless leg syndrome. So something to consider. Some antidepressant medications, including amitriptyline, can make restless legs worse. So something to consider if you're being started on an antidepressant and you have restless legs, to see whether or not, your restless legs are getting worse afterwards. Snoring, lots of things that you can do. You can stop smoking, those are people who do weight loss, and then positioning are very helpful for snoring. You've got these big supportive pillows that encourage you to sleep on your side, these bumper packs. The old-fashioned way of doing that is to sew a tennis ball into your t-shirt. So when you lie on your back and snore more, it actually stimulates you to revert and go onto your side. And then there are these variety of different dental devices that you can use to mitigate snoring. So in terms of insomnia, what are the key things? These are the take-home messages, really. These are the evidence-based things that you can do to try and reduce your chances of having insomnia, or to treat insomnia if you have it. So the key thing, the number one thing to talk about, is setting a morning anchor time. So even though this is difficult for lots of people, getting up at the same time, 7 days a week, setting that consistency and routine is probably the most helpful thing that you can do, regardless of how well you've slept the night before. So it's difficult to do, it's difficult to stick to, but people with migraine benefit from routine and consistency, and that morning timing is probably the most important thing. Strengthening your biological signals by getting morning daylight as soon as possible is also a sensible thing to do, and avoiding napping. So every time we nap, we're reducing our sleep debt a little bit. We stop that sleep debt from rising through the day. It's got to rise at a set rate to enable us to sleep properly at night. Every time we nap, we're eating into that sleep debt and stopping it from rising properly. Things to help mitigate naps are changing temperature. So if you're in a warm room, go to a cooler place, go outside for a couple of minutes. Chewing, it's very hard to fall asleep if you're chewing a carrot stick or chewing gum. And going for a short walk are things that you can do to sort of stave off that napping feeling in the evening. And then this is the key thing. People make a real mistake of treating themselves to an early night, and they lie in bed awake for 2 hours. So only go to bed when you're feeling sleepy tired, when your eyes are heavy, they're about to close. That's the time you should be getting into bed, not going earlier, not saying I slept atrociously last night, I'm going to go to bed at 9 o'clock tonight. So trying to avoid that sort of behavior is very important. What about environment? Well, the bed in the bedroom should be solely for the purposes of sleep and intimacy. That's an exclusive list. Nothing else should take place in the bedroom. No reading, no watching TV, no winding down, just sleep, just intimacy. And if you're lying awake in bed, frustrated, unable to get to sleep for longer than about 15 minutes, then leave the bedroom. So your mind, as you go into the bedroom, thinks, oh, I'm going into this torture chamber where I'm just going to lie awake overnight. Try and break that association by having somewhere else that you can get away to, a nest area outside the bedroom, if possible, where you can do something you enjoy until, again, you're sleepy and tired enough to go back to the bedroom and try and initiate sleep. Otherwise, you're just lying in bed feeling like you're being tortured, and your brain starts to associate your bed being the place where you just have this horrible experience of not sleeping. The other thing to do is have a bit of a buffer zone between ending your day and going to bed. So the act of writing things down on paper with a pen, neurologically, we don't know why this is over, say, typing something into a phone. The act of doing that discharges those thoughts from your brain. So write down what you've got to do tomorrow, write down things that are on your mind, positive thoughts, negative thoughts, just quite simple. Spend 2 minutes doing that, discharge it all onto a piece of paper and leave that outside the bedroom. Now, having a bath or a shower serves two functions. One is it raises your body temperature and then cools your body temperature once you get out of the bath or shower. That helps stimulate melatonin secretion, strengthens the brain's signals that this is nighttime, and it also just helps relax you. So a very sensible thing to try and do each night. And then we have progressive muscle relaxation. If you Google progressive muscle relaxation, there are some really good NHS videos. Newcastle's got a very good audio guide to practicing progressive muscle relaxation. If you do that as part of this buffer routine every night before you go to bed, over time, that can be really, really helpful. Now, what's sleep hygiene? So people talk a lot about sleep hygiene, and I've put Tracy Emin's bed here. That's not really what sleep hygiene's about. Sleep hygiene is about what your approach to sleep is. So how much caffeine are you having before you go to bed? Are you drinking lots and lots of water and then getting up and peeing all night? Are you drinking alcohol? So alcohol actually causes insomnia. It doesn't help you to sleep. It really can cause insomnia in the longer term. And when are you eating? If you're eating a meal just before you go to bed, then that's going to disrupt your sleep. So it's thinking about your behavior before you get into the bedroom. It's also exercise. What time are you doing exercise? If you're doing it late at night time, that's more likely to disrupt your sleep. What type of exercise? Aerobic exercise is probably worse in terms of sleep late in the evening than something more relaxing like yoga. What's the temperature of your room like? Is there any noise intrusion? What's the light intrusion? Do you have a cat that jumps on your bed 3 or 4 times a night that interrupts your sleep? You know, they're all really important things to consider when you think about sleep hygiene. So what's cognitive behavioural therapy for insomnia? Well, that's all of what we've just talked about, but done in a very structured, very taught way over 5 weeks. But there's one caveat for people who have migraine that's really important to talk about, and that is part of cognitive behavioural therapy for insomnia is something called sleep restriction. What you don't want to do is have sleep restriction if you suffer from migraine. You want the alternative, which is sleep compression. I'm just going to describe what the two things are. So sleep restriction, the top line here is everything in black is somebody being asleep, everything in white is them being awake through the night. So you can see that their night is fragmented, there's sleep, wake, sleep, wake, sleep, wake. Sleep restriction takes all of the periods of wake out and says you can only stay in bed for the time that you're asleep. So it really sort of brutally kind of restricts the amount of time in bed that you have. And then week by week, it lengthens it. So it might be you spend 9 hours in bed, of which you're spending 5.5 hours asleep. So brutally, right at the beginning, you're only allowed to be in bed for 5.5 hours. And then week by week, that's slowly sort of lengthened out. That's pretty, I mean, people do it, but it's quite a change for somebody's brain who has migraine. And the gentler way of doing this is with something called, I'm just seeing if I can go through here, something called sleep compression. So sleep compression is the gentler way in which it's squeezed very slowly rather than restricted and then sort of stretched back out. it's squeezed down more slowly. So that's a nicer way of doing these two techniques if you have migraine. So it's just something, if you are going for cognitive behavioral therapy for insomnia, something to tell the therapist about is that you have migraine, and that maybe sleep compression would be gentler than sleep restriction. So what resources can you use? Well, there are these two good books by Colin Espy and Kirsty Anderson that take you through a guided approach to cognitive behavioral therapy for insomnia. And then there are these two web platforms, Sleepio and SleepStation. Some GP practices subscribe to these, so they are freely available on the NHS, but a lot don't, and they do come at a cost. So the other way to look at this is some IAPT, that's improving access to psychological therapies. Some IAPT organisations within the NHS will have sleep modules. So it's always worth checking your local IAPT to see if they have sleep and insomnia modules. But these are some sort of self-help guides that you can try, and they're evidence-based. So there's not really any quackery involved in these, which is very useful. So in summary, and I've gone over by 10 minutes, I apologize. It's a very complicated relationship between sleep and migraine particularly. Lots of it we don't understand. There are multiple levels of interaction. And I think probably the key thing for people to take home is people with migraine have, their brains are wired for consistency and routine. When that routine and consistency is deviated from, that's when the migraine is more likely to happen. So actually paying attention to your sleep and your sleep behaviors and how you regulate your sleep can be a useful thing to do, not only to improve your situation with migraine, but potentially to say, stop the migraine getting worse. Anyway, I hope that's been useful, and I'm looking forward to some questions now.